My name is Dyrskjøt. I'm Professor of Molecular Medicine at Aarhus University here in Denmark. So my presentation was about circulating tumor DNA in muscle-invasive bladder cancer. Circulating tumor DNA is a very promising prognostic biomarker for identifying metastatic residual disease at an early time point, and it's also a promising biomarker for monitoring treatment efficacy. The next steps in these studies, beyond the prospective studies that we have performed, is to do clinical trial validation of these circulating biomarkers in order to determine if there is a clinical benefit of actually using these in a clinical setting. So all cells shed DNA into circulation. Normal and healthy cells, they shed DNA and at different levels, and cancer cells has mutated DNA, and this mutated DNA is also being shed into circulations. So this is circulating tumor DNA, and that is and we are able to measure this circulating tumor DNA in various levels in patients with cancer. Some patients have high levels of circulating tumor DNA, and some have low levels of circulating tumor DNA. The DNA in circulation is highly fragmented, so we need to design some very specific and sensitive assays in order to identify this mutated cancer DNA in the bloodstream. So I think the way we should look at circulating tumor DNA is that it's a molecular handle on the disease, and it's a way of detecting minimal residual disease at a very early time point. And when we have this molecular handle and biomarker, it's possible to guide the treatment of patients at some early time points, and that means that we can actually give adjuvant therapy to patients that have high risk of developing metastatic relapse. So in that way, it's a very promising biomarker for guiding treatment decisions. So again, I think we should. It's not really. It's not a marker of specific treatment efficacies. It's a marker of tumor burden in the blood. So in principle, it can determine, and we can use it for monitoring treatment efficacy in multiple cancer forms and also in different treatment settings. So when we see the efficacy of for instance, atezolizumab in circulating tumor DNA positive patients in the IMvigor010 trial, this is a measure of this result of selecting patients with minimal residual disease, and then we can see that these high-risk patients then have an advantage of receiving the immunotherapy. So I don't think that it's a question of different treatments or anything, but it's more a measure of is there a circulating tumor DNA in the plasma, and if there is circulating tumor DNA, then there is an elevated risk of metastatic disease, and then we can use that for guiding the treatment and treating the right patients. So the next step is actually to do these clinical trials to see if there is an added benefit of using circulating tumor DNA. So we know that ctDNA is prognostic and maybe also predictive for different treatments, but we don't know if there is an increased survival benefit by doing this. And then we have to do some different clinical trials in order to see that there is a survival benefit of using this marker. So it can be survival, but it can also be quality of life, for instance, and that's an important measure also to include in the different clinical trials that we're going to do. So there is one clinical trial ongoing in the IMvigor011 trial on atezolizumab, and we're also doing a clinical trial called Tombola, where we are treating patients with atezolizumab after cystectomy, and then we hope that this earlier treatment of high-risk patients will show that we can select patients for high-risk patients for treatment, and we can also start treatment early on high-risk patients, and in that way hopefully increase the efficacy of the treatment.